Hi, everyone. Thank you for joining today. This is the third session in our Age-Friendly Geriatrics Education Tele-ECHO series on chronic disease in older adults. This series has been organized by our UC Irvine Division of Geriatric Medicine and Gerontology and our Geriatrics Workforce Enhancement Program. Again, thanks for joining us today. We're going to go ahead and get started. This is the structure of our session today, following by welcome, introductions, and announcements. Our didactic today is focusing on an update in osteoporosis care. And we'll have a case discussion and followed by closing and reminders. To make sure the sessions run smoothly, you have been muted upon entry. So if you do want to speak, feel free to unmute yourself at any time. If you have any questions along the way for any of the hub team members or speakers, please go ahead and add your questions in the chat as well. If you want to speak up, introduce yourself with your name and location prior to speaking. And if you're speaking about a client case, always maintain confidentiality when speaking about your patients. This session is CME accredited. And our main objective is to educate community and rural healthcare providers in age-friendly geriatric patient care, treatment, and management, and to expand access to geriatric specialty care throughout California and beyond. Again, this session is 1 CME credit. If you attend all the sessions in this series, you will receive 6 CME credits. Please be sure to fill out the CME attendance form that is sent to you after this session. Our series is a part of the HRSA Geriatric Workforce Enhancement Grant at UCI, and this information or content and conclusions are those of the author and should not be construed as the official position or policy of HRSA, HHS, or the U.S. government. We can go ahead and start to introduce ourselves. If you're on the line right now, please go ahead and introduce yourself via the chat function with your name, role, and site location. We would love to see where you're all joining us from. And we'll go ahead and have our hub team introduce themselves. My name is Nika Seville, and I'm the grant manager for our Geriatric Workforce Enhancement Program here at UCI Health, and we're in Orange County, California. And then I'll go ahead and have our hub team introduce themselves. Who's on the line? Dr. Gibbs.
Hi, Dr. Lisa Gibbs here, Chief of Geriatrics at UCI, and we are all very happy that you're here with us today and looking forward to a wonderful presentation. Thank you.
Thank you, Dr. Sagal.
Welcome, everyone. I'm Sonia Sagal. I'm a clinical professor in geriatrics here at UC Irvine.
Thank you, Dr. Gurbich.
Hi, I'm Tanya Gurbich. I'm a clinical pharmacist. I am a professor at USC School of Pharmacy, and my practice site is UCI Medical Center. Thank you.
And Dr. Campbell. Thank you, Dr. Gurbich. Dr. Campbell.
Hi, my name is Sarah Campbell, and I'm a clinical faculty at the UCI School of Nursing. Thank you, and a family nurse practitioner.
And Carlos.
Happy Friday, everyone. My name is Carlos Garcia, and I'm the data analyst for our Geriatric Workforce Enhancement Program. Welcome.
Thank you all. And it looks like we have some Jerry fellows on the line, a lot of people from Irvine, Anaheim, Pennsylvania, USC, Oroville, California, Santa Ana, UNT Health Science Center in Texas, and Concordia. So thank you all for joining us today. We're going to go ahead and move on into our didactic presentation. And again, today's topic is on an update in osteoporosis care presented by our hub team members, Dr. Sonia Sagal and Dr. Tatiana Gurbich, who practice here at UCI Health and Senior Health Center. I'll go ahead and
Good afternoon, everyone. Thank you for joining us today on our presentation regarding osteoporosis. It's really my pleasure to be here today to co-present this topic with Dr. Tatiana Gurbich, our clinical geriatric pharmacist. And the way our session will run is I'll talk a little bit about the background of this condition, the epidemiology and diagnostic considerations, and then Dr. Gurbich will provide a deep dive into medication management for osteoporosis. Our objectives today, we're going to review the osteoporosis and osteopenia or low bone density definitions. I know you guys are all familiar with this, but we'll just review it briefly. We will remind ourselves of the risk factors that predispose patients to bone loss, and we will talk about how to screen for bone loss using the DEXA and how to interpret those DEXA results. And then we'll discuss strategies to prevent bone loss in our patients. Next slide. So osteoporosis really is the silent disease. Although many patients come to me each year saying they have osteoporosis because their bones hurt, their joints ache, and they feel like that is the telltale sign. This is a silent condition. The joint aches and pains my patients complain of usually those are related to osteoarthritis, not osteoporosis. There are no symptoms, physical exam findings, or lab abnormalities that we see and from osteoporosis, unless it's really too late when people start to fracture and have fragility fractures. So the goal here is to identify and treat those at risk before the first fracture occurs. Next slide. So osteoporosis, of course, affects people of all ethnic backgrounds. There is a high prevalence of this condition. So there are about 2 million osteoporotic fractures in the US annually. About 50% of postmenopausal women and 20% of men over the age of 50 years old will have a fracture related to this condition in their lifetime. And there are serious consequences to these fractures. So there's a decrease in their quality of life, pain, loss of function and independence, and there's a high morbidity and mortality. 20% excess mortality in a year after hip fracture. And the death rate for men who suffer this kind of fracture is nearly double that of women. Next slide. So why is this happening? Really, we are undertreating, certainly women, as it is more common in women, we are undertreating patients who have osteoporosis. So this was a study that looked at women who met criteria for treatment for osteoporosis. Of this group that they looked at, 16% were not taking calcium, about 19% were not taking vitamin D, which really are the building blocks for bone metabolism. About 52% were not exercising more than 2 hours per week, which is important for bone building as well. And about 35% were not receiving the appropriate therapy for their osteoporosis. And then additionally, another barrier to optimal management for osteoporosis is there's low adherence to medications. So patients do have significant concerns related to the bisphosphonate drugs. I think a number of years ago, there was a lot of press related to side effects and complications related to the medication, like jaw osteonecrosis or atypical femur fractures, which really don't pan out when you look at the numbers of people who suffer those side effects, but there's low adherence because the medications are also not easy to take. Next slide. Next slide.
Sorry, 1 second, it's frozen.
Thank you. So this was another interesting project that looked at unrecognized vertebral fractures on X-ray. And this was a project that reviewed X-rays that were done for other reasons in hospitalized women who were 60 years of age and older. And so they looked at 934 patients, and on review of people who had chest X-rays that showed vertebral compression fractures, right, which is a hallmark finding for someone that has osteoporosis. In the radiology report itself, only 52% had a fracture mentioned in the report. 23% had the fracture mentioned in the summary. And as you know, oftentimes as clinicians, we look at the summary of that radiology report. We're not necessarily looking at every single detail. Only 17% had osteoporosis as a diagnosis listed in the medical record for the patient, and only 7% were on treatment for osteoporosis. So this is a very under-recognized and under-treated condition. Next slide. So how do we help patients preserve bone strength? So we need to, first of all, identify patients at high risk. And this can be done looking at the guidelines for screening. So who do we screen? And we'll go over that briefly. Looking at high-risk medications or chronic conditions. And making sure that those people are adequately taking calcium, vitamin D, and performing bone building exercises, and really advocating for pharmacological therapy if appropriate. But the first step really is to identify these patients. So what is osteoporosis? This is just a microscopic look at bones. We have normal bone on the left. It's nice and dense. You can see all the bone connections there. And in someone with osteoporosis, there is significant lack in this bone density. Next slide. So, bone health and bone strength is really on a continuum. And this continuum starts, at a very early age. So between puberty and into our mid-20s and 30s, our bone mass is increasing rapidly through good diet, through hormonal changes, and we really do reach our peak bone mass during these years. And if for some reason, if we don't have adequate nutrition or we have a condition that is preventing us from reaching adequate bone mass, we are about to be at higher risk for osteoporosis later in life. So good nutrition, diet, exercise early on, very important, because we do want people to reach that peak bone mass when they are young. Bone mass and strength is really stable between our 30s and 40s. And then as we hit menopause into our mid 40s and 50s for women, there is rapid bone loss, over 7% per year for over 7 years. So that's a significant deterioration of bone for women during that period of time. Postmenopausally into late life, women do continue to lose bone, although at a much reduced rate. And this continues on. For men, due to their testosterone levels, they do not lose bone as rapidly as women, and we really see cortical bone loss at an accelerated rate in men much later, usually when they're in their mid-70s and beyond. Next slide. So what's happening with bone? So, our bones are active and they are actively remodeling. Bone building is done by osteoblasts, and then the osteoclasts are resorbing bone. So there has to be this fine balance between the blasts and the clasts so that we have adequate bone density and strength. And then, of course, bone remodeling becomes unbalanced. And the main drivers for this in women are menopause and aging in both men and women. And when resorption increases more than formation, we have loss of bone. So just to kind of hit home with menopause a little bit more, our osteoblast activity decreases, bone resorption increases, and actually studies are looking at growth factors, which also might become impaired and result in decreased blast formation. So there's lots of look into this to see how we can impact the development of osteoporosis. So definitions for bone loss. So osteoporosis, of course, is a T-score less than -2.5, and it's measured preferably at the hip and at the spine. And this is a measure that's compared to young adult healthy folks. Osteopenia, or what we now call low bone mass, is a T-score less than -1, but greater than or equal to -2.5. So bone loss really on a continuum. You have normal bone, you may experience some deterioration and fall into the osteopenic or low bone mass category. And then if that progresses further, you become osteoporotic. Next slide. So what are some risk factors for bone loss? Of course, increasing age. If you have had a history of a previous fracture, if the patient is someone who has a low level of physical activity. So we know that bedbound patients, for whatever reason, or skilled nursing home, long-term care facility patients who are primarily bedbound have very low bone density levels. I have a patient who has cerebral palsy. She's wheelchair bound, has never been able to participate in bone building exercises due to her condition, and her bone density is very, very low. Folks who require glucocorticoid therapy for prolonged periods of time are also at risk. People who are underweight or have eating disorders such as anorexia nervosa also have are the risk for developing osteoporosis. Family history, so if grandma or mom or grandmother or family members have had a hip fracture, that should be taken into consideration. There is a higher prevalence in the Caucasian and Asian ethnic groups. People who drink excessive alcohol, so more than 2 drinks per day, excessive caffeine or tobacco use. And in fact, when I was a resident in training, I had a patient who had a foot fracture that would not heal despite having been immobilized for months and months. And we found that she was a smoker, and once we had to really extensively counsel her to stop smoking, and she ultimately was able to heal the fracture, but it was a very prolonged course due to the tobacco use. Rheumatoid arthritis, and then of course low calcium and low vitamin D intake. Secondary causes for bone loss. So there are many chronic conditions that patients experience that can put them at risk. And several are listed here. So diabetes, Cushing's, primary hyperparathyroidism, hyperthyroidism. So if it's hyperthyroidism in and of itself or related to excessive levothyroxine use. Patients who have hypogonadism, women who undergo premature menopause, inflammatory bowel disease, kidney disease, multiple myeloma, and of course medications, which I know Dr. Gurvich will go over in detail. So how do we screen for bone loss? It's pretty easy. The dual energy X-ray absorptiometry, or DEXA, is of course the gold standard test. I do have patients that will go to community screening events that they pay $99 for, and they'll have 3 or 4 different screening assessments done, and they'll have an ultrasound assessment of their heel and then be told that they have osteoporosis. And that is not the way we diagnose osteoporosis. We do not advocate for that kind of testing, and I often have to educate patients to save their $99 to not undergo that, and to rather have the DEXA performed. Next slide. So the DEXA scan will, the DEXA report, if you order a DEXA, usually comes back with an assessment from the radiologist, which includes a frac assessment. And this is helpful to determine which of your patients really will benefit from pharmacological therapy. So this is a statistically robust fracture risk prediction tool, and it was developed by the World Health Organization. It combines bone mineral density and clinical risk factors to predict risk factor analysis and to determine what the 10-year probability of a major osteoporotic fracture is, generally at the hip or spine. And it's used to determine treatment, whether treatment is appropriate for patients who fall in the osteopenic or low bone mass category. And if you look at the results of your bone density test, the frac assessment is generally a paragraph at the end of that results page. So what are the benefits of completing a frac? So it does assist us in treatment decisions for osteopenic patients. It helps us to determine which patients truly will benefit from bisphosphonate therapy. So when I was in training about 10, 15 years ago, we did not have the frac assessment, and every single patient received a bisphosphonate. They either received full dose bisphosphonate or half dose bisphosphonate. So if you had a bone density that was in the osteopenic category, you received half dose bisphosphonate. And if you were truly osteoporotic, you received full dose. But studies subsequently showed that not all patients who are osteopenic require pharmacologic intervention. And so the frac tool helps us to determine for which patient it is cost effective to have pharmacological therapy. And it helps us really to avoid giving medications to those who are low risk and have little to gain from treatment. So in terms of bone density testing, the USPSTF recommends bone mineral density testing for all women who are over the age of 65 years of age, regardless of risk factor. But we should also consider testing in women who are less than 65 if their 10-year fracture risk is equal to or greater than a 65-year-old Caucasian woman without additional risk factors. And the USPSTF recommends or states that there is insufficient evidence to recommend screening in men. There are guidelines that are also put out by the NOF, or the National Osteoporosis Foundation, and they do recommend screening all men greater than 70 years of age, regardless of risk factors. Now you might be wondering, so how do you determine whether a woman who's less than 65 years of age, what is her risk of having a fracture? You might wonder that. And interestingly, if you go to the FRAC's website, so you could type fracs in your search engine, and it will take you to a very robust website where you can enter in your patient's age, weight, tobacco, alcohol history, history of family, family history of fractures and other chronic conditions. And you do not need the bone mineral density score to assess someone's risk for fracture. So that's also a very elegant way to use the fracs in someone who has not had a bone mineral density, a DEXA assessment. So the guidelines state that it's critical to scan a patient on the same DEXA machine in the same position, given that there can be inter-machine difference. And how do you translate this clinically? So ideally, we do want to use the same type of machine. And if we can get the patient to go back to the same institution where they had their bone density done previously, that's going to give us the best and most accurate results. But if that's not, if that's not possible, we work around that. So who do we treat? So postmenopausal women and men over 50 who meet criteria for osteoporosis by DEXA or have a history of hip, vertebral, or prior fragility fracture really should be treated pharmacologically for osteoporosis. And so if they have osteoporosis by DEXA, it's pretty clear that they do require medications in addition to calcium, vitamin D, and bone building exercises. Where there's a little bit less clarity is if someone has low bone density or osteopenia. And the thought there is that if the 10-year probability of hip fracture is greater than or equal to 3%, or the risk of a major osteoporotic fracture is greater than 20%, as calculated by the FRACs, those patients should be treated with pharmacologic intervention. Now, you might be wondering in terms of what is the time needed for effective treatment for someone who has been diagnosed with osteoporosis, or when do you consider no longer getting a DEXA scan? And treatment should be considered in any patient with greater than 1 year of remaining life expectancy. This is because the time needed to treat for benefit is actually fairly low. There are no clear guidelines for when to start intervention after a fragility fracture. So if someone has not had a bone density test, they have a fragility fracture, you may get the DEXA scan immediately following the injury and find that they're osteoporotic. Generally, it's recommended to start 14 days after the acute fracture period. And the decision to treat is based on patient preference, of course, fracture risk profile, risk and benefits, and cost of medications. And I know Dr. Gurvich will talk about some of the limitations in terms of the administration for commonly used medications for osteoporosis. Next slide. Now, there are several labs that are recommended for an initial workup for those who are found to have osteoporosis. And you can consider all of these or some of these. Generally in my clinical practice, I usually will get a complete metabolic panel to look at renal function and albumin to get an indication of their nutritional status, maybe alkaline phosphatase. I generally get a TSH because hyperthyroidism, or someone who's over-replaced for hypothyroidism, does have a higher risk for bone loss. I usually do look at a vitamin D level, although that's fairly controversial in some schools in terms of mass screening for vitamin D. But if someone is very deficient in vitamin D, I do adequately try to replace that. And in a male patient, I might consider assessing testosterone levels. Next slide. So So in terms of treatment options for osteoporosis, I wanted to just touch on exercise. So as I mentioned before, a marked decrease in physical activity or immobilization, being bedbound, does lead to a decline in bone mass, and this can occur actually a lot more rapidly than you'd think. And walking, which is a weight-bearing exercise, can be recommended for all adults. So just as good general health, we do recommend a walking program, and certainly do emphasize that in patients who have low bone density or osteopenia, certainly for those with osteoporosis. And of course, we would recommend to start slowly and gradually increase the number of days and time spent walking. And regular exercise is associated with, it's positively associated with bone mineral density. And this can be started even in later life to help preserve their bone density. And it's important to remember that they should walk on, probably not the sidewalk, but if they can find a sort of softer, hard surface to walk on, that would be best. Now, how often do we monitor someone who has osteoporosis or osteopenia? So serial bone mineral density testing while on therapy is common, and we usually we usually perform the DEXA every 2 years, and that's covered by Medicare. It's less clear how often to screen somebody for osteoporosis who's had a bone mineral density test that was normal. So some studies that I looked at said every 4 years or every 6 years, but I'm not sure that there's a consensus necessarily on someone who has normal bone density and is over 65. Serial bone mineral density testing is useful to identify patients who are losing bone mineral density despite being on treatment for osteoporosis, and it might give you an idea that they are not adherent to treatment, or that they have a very low vitamin D or some other secondary cause of osteoporosis that isn't being adequately managed in conjunction with their osteoporosis treatment. And then, of course, compliance should be assessed at every visit, especially when patients are taking bisphosphonates, since they are somewhat difficult. There's a difficult administration for those medications. And then, of course, poor compliance is associated with an increased risk of fracture. So I'm going to turn it over to Dr. Gerbish to talk about medications. Thank you.
Thank you, Dr. Sagel.
Okay, now we're going to talk about the medications used to treat osteoporosis. Next slide. So we're going to review some medications that are risk factors for osteoporosis, and then talk about different classes of drugs that are available to treat osteoporosis, and talk about some risks, side effects, and monitoring parameters that you need to do if your patients are being treated pharmacologically. Next slide. So this table was taken out of the National Osteoporosis Foundation. If you look closely, it's a little bit screwed up. Like, for example, the proton pump inhibitor area right here, it's also got selective serotonin reuptake inhibitors. So I don't think a clinician developed this table, but just look at it at your own time. Basically, most of these drugs, the way they cause osteoporosis is reduce osteoblast formation. So for example, things like heparin, some of the older anticonvulsants like dilantin and phenobarbital, they all do that. Glucocorticoid are obviously on here. You know, it's generally high dose that puts patient at risk, but here they mark it at 5 milligrams or greater for treatment for more than 3 months. So that's important to keep in mind. Lithium can increase the risk of osteoporosis as well. In terms of proton pump inhibitors, are very commonly used. That's one of the reasons not to use them long-term, because they inhibit calcium absorption, and there is an associated risk with fractures. And then with SSRIs, there's a lot of animal data to show that long-term administration leads to osteoporosis, less human data, but it is advisable to make sure that patients on long-term SSRI therapy do get regular screenings. Obviously, Dr. Sagel already mentioned thyroid replacement, and over-replacing the thyroid could potentially cause a problem. And things like Actos, which we sometimes use in diabetes still because they're relatively inexpensive and fairly effective drugs, they also decrease bone formation and also work on the estrogen piece of it to increase osteoclast activity maybe. So it's a complex mechanism by which lactose causes osteoporosis. Next slide. So let's spend a little time talking about calcium and vitamin D supplementation. So older patients, men and women, require 1,200 milligrams of vitamin D daily. This is a lot of calcium to get from diet, but patients do have some calcium containing products on a daily basis. So what I usually do is figure out what they're getting from diet. You know, a glass of milk is 300 milligrams, a yogurt is 200, a slice of cheese is another 200. So you add all that up and you basically supplement the rest. So most of your patients are going to probably need an extra 500 to 600 milligrams of calcium daily if they're getting something from diet. In terms of vitamin D, to maintain a normal level of 30 to 50, you need 800 to 1,000 units daily. Most of our older adults are going to be insufficient in their vitamin D, so levels between 20 and 30, and those require 2,000 units of vitamin D a day. If you're truly deficient and your levels are less than 20, you will get a 50,000 unit capsule that you're going to administer weekly for 8 to 12 weeks. And that usually brings the level up to within normal range. And then what you want to do is follow that up with a maintenance dose of about 2,000 units daily. Sometimes that piece falls through the cracks, so it's really important to get the patient on to a regular vitamin D treatment once the very low level has been corrected. Next slide. So calcium doses are typically 500 to 600 milligram per tablet. That's actually the most that can be absorbed at a time. So those patients who want to double up their pills and take them all at once are not going to get the full benefit of the full dose. And those who like giant pills that have 1,000 milligrams in each are also not getting the full benefit of that. So you really do want to split up the dose to 500 or 600 with each dose. Calcium carbonate is probably the most common form of calcium available. It's also the one that produces the most side effects like GI upset, constipation, bloating. Some people even get diagnosed with irritable bowel disease because they're on so much calcium. So that's something to keep in mind. And many patients take multiple sources of calcium. So it's important to bring all that into the office and figure out exactly what their total daily dose of calcium is. Citracal listed here is calcium citrate, which is a better absorbed form of calcium because it's got that citrate moiety in it, better absorbed and also better tolerated, less bloating and less gas. You have to keep in mind the drug-drug interactions with some commonly used medications like loops, for example, decrease calcium, thiazides, especially at higher doses of say 50 milligrams or higher of hydrochlorothiazide or 25 milligrams or higher with chlorothalidone will increase calcium levels. Proton pump inhibitors and H2RAs will decrease absorption. And when patients are taking their levothyroxine and fluoroquinolones and they're also taking calcium, you want to separate them by at least 4 hours. In terms of vitamin D, there are lots of combinations of calcium and vitamin D. Look at the supplements your patients are taking because a lot of the supplements do not contain enough vitamin D in it. Most multivitamins for seniors will have enough D, but not enough calcium. So you really want to make sure that everything they're taking is appropriate and dosed correctly. Typically, there's really poor adherence with over-the-counter calcium supplements just because I think they're really poorly tolerated. Again, a lot of gas, a lot of bloating. And for your vegetarians or vegans, the preferred vitamin D source is vitamin D2 because it's plant-derived. Next slide.
We have some questions on that specific topic if you want to answer them right now.
Actually, could I go through the slides because I have a lot? So I'll answer questions at the end if we could hold on.
Okay. Yeah, that's fine. Okay.
Thanks. So when you're talking about prescription meds, you're dealing with two mechanisms of action. One group that decreases osteoclast activity, and the other group that increases osteoblast formation or osteoblast activity. The majority of the drugs will reduce resorption, and so these are listed here. And then the only one that's an osteoblast formation drug is a parathyroid hormone analog, which is Forte or Tymlos. Evenity, which is the newest agent on the market, actually does a little bit of both. It primarily increases osteoblast formation and secondarily reduces osteoclast activity a little bit. So it's kind of a combination drug. Next slide. So the next several slides are kind of busy. They have a lot of information. I really encourage you to look at the slides after I'm done. I'm not going to go through each point on the slide because there's just not enough time, and I don't know that it's absolutely necessary. But these are basically all of your bisphosphonates. There's not a whole lot of difference between them. Alendronate is probably the most studied bisphosphonate, and that's the one we use most often. It can be used for prevention at half the dose and treatment for a full dose in both men and women. You've got Resindronate, which is a similar product. It can be used weekly, daily, or monthly. Boniva is available IV and PO administered monthly. I think there's less data with Boniva in general. And then there's Reclast, which is IV only bisphosphonate that's administered once a year for treatment and every 2 years for prevention. Next slide. So when you're looking at sort of clinical pearls of these drugs, the biggest issue with bisphosphonates taken in oral form is how they're administered. You have to remain upright in a sitting or standing position for at least 30 minutes with most bisphosphonates, and Abandronate actually requires a 60-minute standing position. So older adults will often have trouble with that. They can't be upright for that long. They may also have trouble swallowing. They may be at risk for aspiration. So a lot of times these oral agents are really not an option for older adults. There are also typical warnings like osteonecrosis of the jaw and atypical femur fractures, which we'll go over in the next few slides, and also a lot of problems with esophagitis and stomach pain in general associated with these drugs, even when they're taken on a monthly basis, although that tends to be a little bit better tolerated. The biggest issue in older patients also is renal function, so you don't really want to use them if your creatinine clearance is much less than 35. And in terms of drug-drug interactions, you really want to be careful with all the other medications that also cause GI irritation, like aspirin and NSAIDs. They have to be separated out with the administration of calcium. And so obviously also long-term use of PPIs and H2RAs also produce drug-drug interactions. Every old medication will sometimes come out as a new brand name. So Benosto is a new brand name for Alendronate because regular Fosamax is now off patent. So this new formulation is kind of interesting. It's got an effervescent tablet. It's got sodium bicarb in it to help with the GI problems, but unfortunately it adds an additional 650 milligrams of sodium with every pill. And obviously in an older adult, that might be a problem because of edema, fluid retention, and hypertension. So not the best option for older patients, and also very expensive. Next slide. So the osteonecrosis of the jaw, it's a relatively low risk, actually, anything from 1 in 10,000 to 1 in 100,000 patients, but every dentist I've ever spoken to talks about it. There are certain risk factors associated with this problem. IV bisphosphonates are more likely to cause this because I think they sit in your body a lot longer than oral things. If there's cancer associated, there's a risk of cancer. Patients with cancer have an increased risk for osteonecrosis of the jaw. Patients with complicated dental histories like multiple extractions or implants, poorly fitting dentures, and some other risk factors are listed here. So what do you do to kind of deal with this potential problem? So if a patient has not started a bisphosphonate yet, what you want to do is get your dental work, major dental work done prior to starting, if that's possible. And then once you're on a bisphosphonate, continue normal dental screenings and cleanings and just traditional dental care. If you're already on a bisphosphonate and you've been on it for less than 4 years and you don't have additional clinical risk factors, it's actually okay to do whatever procedure from a dental standpoint that's needed, provided it's necessary. If you're on bisphosphonates for more than 4 years or you're on chronic glucocorticoid therapy, what the recommendation is to stop the bisphosphonate for 2 months, prior to the dental procedure, and then resume bisphosphonates once everything is healed. Next slide. Atypical femur fractures are also a possibility, and I think they happen because, you know, most of these drugs sort of screw with bone remodeling by decreasing osteoclast activity, and that may lead to increased skeletal fragility in general. The absolute risk is fairly low, although there's very little data on long-term problem with this, because most of the data is capped at 5 years, because most people are on these drugs for 5 years and then you take a holiday. But there's some risk factors associated with an increased risk for these fractures, and this would be longer duration of treatment, more than 5 years, if you're Asian and if you're on long-term glucocorticoid therapy. And you know, the risk does decline when bisphosphonates are stopped and when we give patients a break from them. Next slide. So the reason to give a break from bisphosphonates is to reduce the risk of osteonecrosis of the jaw and the atypical fractures. For your low risk patients, you might consider giving them a break 4 to 5 years after starting bisphosphonates. And for your high risk patients, maybe 6 to 10 years after starting bisphosphonates. And there's really very little data and guidance on how to or when to restart therapy at this point. Next slide. The next set of drugs, there's just one in this class. It's called Prolia, and it's a monoclonal antibody. And what it does is it reduces osteoclast formation and decreases bone breakdown. This is a reversible kind of action. So once you stop Prolia, what happens is there may be significant bone loss after Prolia is stopped. So this is a drug that's administered in the doctor's office. Usually we refer to endocrine for this, 60 milligrams sub-Q once every 6 months. And this drug is primarily used in those patients who cannot tolerate a bisphosphonate orally. It's a drug of choice for patients with renal insufficiency. There is a risk for hypocalcemia, even in patients who have no other risk factors. So no CKD, for example, but they'll still develop acute hypocalcemia. So it's important to monitor calcium levels. There's still a warning of osteonecrosis of the jaw and atypical fractures. And the side effects are kind of 1 to 10% of the patients will develop a hypertension, fatigue, arthralgia, edema. Usually it happens within 3 days of the shot being administered. Next slide. So Prolia discontinuation. If the next shot is delayed by 16 weeks or more, there is an increased risk for more fractures. They actually did a study on this where abrupt discontinuation or not continuing with therapy did lead to an increase in multiple vertebral fractures 7 months post discontinuation in patients who received at least 2 doses or a year's worth of Prolia, basically. And so if the delay in therapy is unavoidable, what you want to do is give the patient a bisphosphonate instead, or a teriparatide or Forteo instead, to kind of maintain some of that benefit you've gotten from the administration of Prolia. Next slide. Then you've got estrogen-based therapy. So obviously you can give patients just HRT, but there are also obviously risks associated with that. And there are 2 other products out there that are, one is Avista, which is an estrogen receptor modulator, which works like estrogen in some tissues and unlike estrogen in others. And then there's a combination product with a different estrogen receptor modulator and conjugated estrogen. So Avista is primarily used in patients who can't tolerate bisphosphonates and have a history of breast cancer because it's used in a preventative measure. It does increase the risk of blood clots like DVTs, VTEs. So you don't want to give it in patients with increased risk for stroke or any kind of clotting problems. with Duave, which has actual estrogen in it, there's also a risk for endometrial cancer, obviously, increased risk for dementia, and all the other risks you normally associated with estrogen use. The biggest side effect of Evista are hot flashes, and that's really the cause to discontinue the drug, because a lot of women just can't handle the increase in hot flashes yet again. And then other side effects are peripheral edema and some joint pain. With Duave, you're not going to get hot flashes, obviously, because you're getting estrogen, but you are going to get some estrogen-related side effects like nausea, vomiting, edema, maybe some breast tenderness. And Duave is really not recommended in patients over the age of 75. And in our practice, that really limits, I mean, actually, I don't think we have a single patient on this medication. Most of our patients are over the age of 75-year-olds or teenagers in our practice. Next slide. The next group of drugs are parathyroid hormone analogs, and there are two of them now. One is Fortea, which has been around for a while, and one is relatively new, which is called Tymlos. They're both injections, sub-Q daily, that the patient administers him or herself. Tymlos is a more effective drug. It binds more tightly to the parathyroid receptor. And studies have shown that to actually against placebo, for it to be more effective than Forteo. There's a black box warning for both of these drugs for osteosarcoma. There's a limit to how long you can use them, which is 2 years. Studies did show that when you're using Tymlos, you actually get a lot of benefit at 18 months. So you may not need to go the full 2 years. And the biggest issues in terms of monitoring is hypercalcemia, which, as you would expect from a parathyroid analog to have. And with Tymlos only, you also can get hyperuricemia. So they do recommend monitoring for calcium and uric acid levels. When you administer these drugs, they tend to cause a lot of orthostatic hypotension and dizziness and increased risk for falling. So you do want patients to be in a lying down or sitting down position when they administer these drugs. And these are really recommended for your very high risk patients who've tried other options. And I think one of the last slides will show the algorithm of when you try what. Next slide. So calcitonin has been around forever. I think it was around before even alendronate came out, if I remember right. The most common formulation of it that we use is a nasal spray. It's probably the least effective of all the osteoporotic medications. And now there's an additional fear of higher incidence of malignancy. There was a FDA review done in 2013 that showed a higher incidence of malignancy with calcitonin versus placebo. So the limit duration is now of treatment is now 6 months due to that malignancy, and it's definitely less effective. So it's further down on the list of things you might try. Next slide. And the last medication that's available, it's kind of a combination mechanism of action kind of drug. It's a sclerostin inhibitor that increases bone formation and also decreases bone absorption. It's probably the most effective medication we have for osteoporosis in terms of reducing fractures. It reduces fractures by 60 or 70% in some of the initial trials. It's a once monthly injection that's administered in the doctor's office. Its biggest issue is the black box warning, which is very prominent on the package insert, obviously, the increased risk for MI, stroke, and cardiovascular death. So you really want to avoid it in anybody with any kind of cardiovascular disease, which eliminates a lot of patients, obviously. There's also a risk for hypocalcemia, the way there is with the other monoclonal antibodies, and the same standard warnings for osteonecrosis of the jaw and atypical fractures. It's also, you have to be careful using it in patients with severely reduced kidney function, because obviously it increases the risk of hypocalcemia. Next slide. So this is kind of the treatment algorithm for osteoporosis. So you start with bisphosphonates, typically alendronate or isindronate. because they're the better studied drugs. If the patients can't tolerate that, you move on to the injectable reclassed, which is a bisphosphonate, or you can offer them Prolia, which is administered every 6 months. For those patients who have, you might recommend raloxifene. For second line agents, again, if they can't tolerate oral bisphosphonates, you would go to an IV bisphosphonate or Prolia as a first line. Then you might go to a bandronate, which is the third oral bisphosphonate that's also available as IV form. And then for those patients with a lot of vasomotor symptoms, you might consider Duave, which is a combination of an estrogen receptor modulator and estrogen itself. For third line agents, you might use Forteo or the new parathyroid analog. Calcitonin is a third line agent, or this last one that I just talked about, the sclerostin inhibitor, which has a black box warning for cardiovascular problems. This is kind of the overall approach of treatment. And I think that's the last slide.
Yes, that is the last slide. We can quickly move into our case presentation, but Dr. Gurvich, there are 2 questions in the chat for you, if you can answer them as well.
Let me look at the chat.
Thank you so much. We have our case.
Should I just
Is
answer? Sorry.
yeah, if you can answer them in the chat, that'd be great.
In the chat, okay.